Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, May 2nd, 2024, we are speaking to Dr. Barbara Taylor. Dr. Taylor is a professor of medicine and associate dean to the MD/MS program at UT Health San Antonio. She is an alumnus of Princeton University, Harvard Medical School, and did a residency and fellowship training at Columbia University, and also received a master's while there from the Mailman School of Public Health at Columbia. Dr. Taylor's research focuses on improvement of health outcomes for those living with and at risk for HIV, with a specific focus on minority populations. She and her colleagues covered the 2024 CROI meeting, highlighting the key data from the realm of epidemiology and ending the HIV epidemic, and that's what we're going to talk about today. Barbara, welcome to the podcast.
Thanks so much for having me, Mike. On behalf of my co-authors, I get to work with an awesome team, Shauna Gunaratne, Hong Van Tu, Tim Wilkin, and Jason Zucker. We're really happy to talk to you about what we covered for CROI.
Right, and just for background, the tradition of this started with Scott Hammer, right? You were brought into this gig, if you will, of covering CROI, because he was doing it initially, and then you did it together with him. Is that how it evolved?
Yes. So I owe my presence here a lot. I owe my entire career to Scott, really. But he famously brought fellows in as co-authors to the section that he reviewed for CROI. And so that is honestly how Hong and Tim and I all wound up reviewing this. And then we have done the same thing, inviting Shauna and Jason, who are our colleagues at Columbia, alongside. So even though I am now in Texas, I still have my Columbia ties.
Well, and to me, it's worth another 20 or 30 seconds just to pay tribute to Scott Hammer, who was a mensch above all. Just the guy was one of the best mentors that I ever observed from a distance, and a researcher initially at Beth Israel and Deaconess, and then took his talents to Columbia, where he was chair of ID for quite a while. And did a lot of work in the ACTG, especially during the development of heart medication. So we'll just dedicate this podcast episode to him.
Thank you, Mike. I love that.
Yeah. So let's go to the CROI meeting. I think one of the things that I noticed in the Epi coverage was this kind of startling presentation to a degree that even if we hit a 95-95-95 goal, and I'll have you explain what that is in a second, we still might not be able to achieve a 90% reduction in transmission by 2030. So let's start with, for those who aren't initiated to the terminology, what does 95-95-95 mean?
Yes, so I was also struck by these data. So 95-95-95 means that in a population, and you can look at that on a country level, you can look at it on a city level, you can look at it in your clinic. 95% of people who are living with HIV know they have the diagnosis, so they've been tested and they know they have the diagnosis. 95% of those folks are engaged in care and on antiretroviral therapy, and 95% of those folks have achieved viral suppression or success with their HIV care. So it gives you it's called the HIV care cascade, and gives you targets for each group of people in terms of where you want to go. And it is the World Health Organization and the Ending the HIV Epidemic efforts all endorse these targets. And what is supposed to happen is if we achieve those targets, we are supposed to basically eliminate the HIV epidemic, because HIV treatment is prevention and we can stop HIV transmission.
Right. And so this all goes back to undetectable equals untransmissible, which is one of the new, relatively speaking, strategies on reducing transmission in the environment. So Tim Hallett in London and others came up with these models that said if you just got 90-90-90 instead of even 95-95-95, that we would have a pretty good reduction, substantial reduction in transmission. So what were these new data about?
So there are, I should say, on a more positive note, there are lots of encouraging data about 95, 95, 95. There's an article just a couple months ago in Lancet HIV that Botswana, Eswatini, Rwanda, Tanzania have all already achieved 95, 95. So there are good data out there. However, if you look at the United States, many of our cities are not on track to meet our goal, which is a 90% reduction in new infections by 2030. And Melissa Schnurr and her colleagues used a model that's the Johns Hopkins epidemiological and economic model to look at the impact of interventions on sort of new HIV infections or HIV incidents. So they looked at four things. They modeled what happens if you increase use of PrEP, what happens if you improve linkage to care, if you increase retention, or if you improve rates of viral suppression. And they modeled those interventions in three different sort of theoretical cohorts. The first was only Black and Hispanic men who have sex with men under 35 years of age, so a specific population. The second was all men who have sex with men and people who inject drugs. And the third was the general population. And their model allows them to do this in specific cities. They used Baltimore and Los Angeles as examples, and then also in sort of 18 metropolitan statistical areas. And the good news, I think, is that the highest impact efforts were those that focused on all men who have sex with men and people who inject drugs. And the highest impact interventions were PrEP and retention and care for people with HIV. However, even if they combined all of the interventions in their model, so all four interventions happened, and they did it across the general population, it didn't lead to a 90% reduction in HIV incidence. And so that was a little bit sobering.
And that was, you think, because maybe there's still pockets of within the population that are don't know they're infected or haven't been tested, and therefore they're kind of out of the picture? Is that what you're thinking?
It's hard to say because this is, just a model, and as George Bach says, all models are wrong, but some are useful. I think this one is useful. There are, as we well know, communities that get left behind by these interventions. And I think that may be the case. We have, I think on the flip side, the encouraging sort of side of this is in countries that have achieved 95, 95, 95, or even cities in the US that have been very successful in terms of addressing their HIV cascade, looking at San Francisco or parts of New York, they have seen decreases in HIV incidence. I think it's communities in some ways like ours in Texas, throughout the US South, where we are really struggling. And a lot of that is access to care.
Yeah. Well, I think it's important to kind of keep reality in our discussions about things, but at the same time, our goals are our goals, and we hope we can do that. But it seems important at this point to just say that the treatment cascade is a part of an overall reduction. And another part of it that we've talked about on these podcasts in a couple of episodes is prevention through PrEP or pre-exposure prophylaxis. And there were some more data presented that talked about long-acting treatments, both in terms of therapy, but also in terms of prevention. What was your take on the long-acting therapies, especially with regard to maybe achieving a 90% reduction by 2030?
Yeah, I think these were some of the most exciting data at CROI, were all the data about long-acting antiretroviral therapy. And so I'll highlight just a couple studies that people might want to take a closer look at. So there's the AIDS Clinical Trials Group study, A5359, which is also called the Latitude study. Adia Rana presented that at CROI. And this is a study where they enrolled 434 participants who had adherence challenges. So this is sort of a real life study where they found people who either had ongoing or intermittent viremia or had disengaged from routine follow-up. And they were randomized to either continuing their regular oral antiretroviral therapy or getting injections with long-acting cabotegravir and rilpivirine. They also were given cash incentives for viral suppression. And they found their primary outcome was virologic failure, greater than 200 copies per milliliter, or discontinuation of the treatment. And it was incredibly encouraging. So only 24% of folks in the long-acting injection arm had virologic failure, whereas 38.5% in the oral ART arm did. So that was a statistically significant difference. And actually only 7% of the people in the long-acting cabotegravir ripivirine arm actually had virologic failure at all. Some of the other failures were for switching treatment. Yeah. So that was really encouraging. The trial was actually stopped early during an interim analysis. So these are 24-week data, but it was really encouraging because it's using long-acting cabotegravir ripivirine in a community where it's not currently FDA approved. It's only approved in people who have achieved viral suppression.
Correct.
But it worked very well.
Just interrupting for a second, we had a 20 to 25-minute podcast interview with Adi Arana while at CROI. He talked about these data, so I'll refer everyone to go to that episode for the real deep details in this. But I think also clinically, around that time, in fact, exactly the week of CROI, Paul Sachs and others presented an update to the IAS-USA treatment guidelines, based some part on these data, but mostly on other small reports that showed that even among people who could not get their viral load suppressed, those who had inadherence to the point where they couldn't have sustained viral suppression, that going just directly to injectable like cabotegravir rilpivirine is now a recommended approach, provided that other things have been tried and have failed and you have the right support systems. Your thoughts on that?
I think it's really exciting. And to be quite honest, if we had more access to long-acting cabotegravir and rilpivirine, I think it would be something that everyone should be trying. There were further data presented. So Matthew Hickey and his colleagues reported further data from the Ward 86 clinic that's at UCSF. They have a cohort of 59 patients that they've followed now for over 56 weeks who started with a detectable viral load. Actually, 70% of them had a viral load of over 10,000 copies when they started. And so these are folks who couldn't achieve, for whatever reason, viral suppression on regular oral antiretroviral therapy. They put them on long-acting cabotegravir ripivirine. They use a different strategy as far as injections. So they give injections every 4 weeks until someone has achieved viral suppression for 3 to 6 months, and then switch to every 2 months, as opposed to the regular protocol for someone who's suppressed. And they have had incredible results. So this is a group of folks who were not virally suppressed. So 81% has achieved viral suppression at 48 weeks. And actually, if they added another antiretroviral agent because of resistance or something, 93% of those folks had viral suppression. They have a really robust adherence support structure. They're very intent on addressing substance use disorder and mental health disorder and transportation and all the other things. Ward 86 is really good at that. But I think it's really exciting to see this working in a real life setting. University of Chicago also presented some data that showed similar findings in their clinic with a smaller number of patients.
So these are kind of harm reduction approaches that are just, as you said, real world. And otherwise, these individuals often just can't get their virus under control in another way. And if 81+% are doing that at 48 weeks, it does take a lot of extra support. You pointed that out, but it's a really exciting time. Transitioning a little bit more to other treatments, I saw some data about moving to long-acting in other diseases like hepatitis C therapy. What did you see in that realm?
So this is also really exciting. These are much earlier in the pipeline studies that were presented at CROI. So there are 2 mouse studies that were presented. The hepatitis C relevant one was Usman Arshad and colleagues co-formulated basically the pan-genotypic anti-hepatitis C regimen, glucoprevir preventasphere.
Mhm.
in a long-acting formula so that it would last 4 months. And they gave it to rats and they injected them into the thigh muscles of adult rats, and it worked. The detectable levels continued for quite some time, and they were levels that would have been sort of rat to human equivalent of appropriate therapy. So there may be, it would be great if there were long-acting hepatitis C therapy on the horizon. And the other study that was also a mouse study, Srijani Das and their colleagues presented early data on a long-acting hepatitis B treatment with tenofovir in mice. And that also had excellent pharmacokinetic parameters. So I think everybody's getting on the long-acting bandwagon because it is, in all of the studies, I should say, it's incredibly acceptable to patients. There's some great data from the adolescent study, the impact study, MOCA, where they talked to the adolescents who were in the study. These are 12 to 18-year-olds. And they found that they all actually had a preference for a long-acting injectable antiretroviral therapy.
Yeah, so that explains why I saw rats celebrating at the meeting. They were excited about these data.
Yes.
Yeah. So
they're very excited about their hepatitis C treatment.
What's remarkable to me, because like you, I've treated a lot of people with Hep C over the years since we've had the direct acting agents. And even though, yes, it's only 8 weeks now, we don't see the adherence issues quite as dramatically as we do in the HIV population. It probably is because it's short term, and we're also going for cure. And people who line up for that, the success rates across the board are about 98% cure after 8 weeks of treatment. But an injectable would, for sure, in my opinion, get those other 2% and make it a little bit easier for folks. So that's a big step forward. Just in the interest of time, let's shift gears and talk about COVID-19 a little bit. There's concern with the new therapies, be it the ritonavir boosted nolimavir, or Paxlovid, people would know it as, or molnupiravir. But concern, like with other viral diseases, that you can get resistance. What did you hear at the meeting about COVID-19 and that particular issue?
So this is really interesting because we know that with COVID, with or without treatment, you can have viral rebound. Like, those data are pretty accepted at this point. And so Trevor Tamura and his colleagues presented data from a study that's called Positives, that stands for Post-Vaccination Viral Characteristics Study. And they're following people with viral rebound to look at whether they get resistance to specifically nirmatrelvir ritonavir, which is also known as Paxlovid, or remdesivir. And the very good news is that they really didn't find a lot of resistance. There was some. It didn't actually really seem that related to medication or medication duration. And they can emerge during treatment, but they don't seem to be the cause of the rebound, nor do the mutations stick around. So that's good news on a couple of fronts. It means that resistance is not really what's causing the viral rebound. And probably even more important is that because the resistance mutations are only very transiently present, they're not likely going to give us transmitted drug resistance like we see for HIV.
Yeah, I think that there's a couple reasons for that from as I'm listening. Is one is that the treatment is only going on for 5 days, maybe up to 10 if you're using remdesivir in the hospital, perhaps, that people use for people who are immunocompromised. But it's not long, and the virus, as you're alluding to, when it achieves a mutation to one of the drugs, it obviously causes a fitness hit, that the viruses don't like it, and they'll revert back towards a wild type. So that is good to know, though, because the questions did come up. As I knew before we started, the time is moving quickly. I do want to get to one other area and then open it to you about anything that I might not have asked about. But the intersection of HIV and mental health, that is a major barrier for, I'd say, up to 40% of patients in our clinic, maybe more. But these mental health barriers often are depression, anxiety disorders. Sometimes there's substance use that's intermingled in this. And for a lot of patients and of course their providers, there's a struggle to kind of get on top of that and help. It seems like this also especially affects younger people and women. And I know there were a couple studies about this. I thought maybe you'd want to touch on that aspect of things, mental health and HIV and that intersection.
Yeah, thanks. And I agree. I think this is one of the major challenges for retention in HIV care, achieving our ending of the HIV epidemic targets, is figuring out how we can effectively treat both HIV and mental health disorders in the same setting in a way that people will access the care. So there is a trial called Search Youth, which was presented by James Ayeko and colleagues. And this is a cluster randomized trial of basically a life stage intervention for 15 to 24-year-olds in Kenya and Uganda, in rural Kenya and Uganda. And they found amongst 622 participants in the intervention arm and 572 in the control arm that they had a significant improvement in depression in the people in the intervention arm. They had but it's still, as you already noted, really high rates of depression. So 53% of the people in the intervention arm experienced some depression during follow-up, whereas 73% in the control arm. But this is a intervention that really supports sort of communication between providers and youth to identify life events, talk about it, and then do rapid referrals to mental health. And it really did work. This same study, actually, they already published data that showed that it also improved viral suppression. So I think that just highlights how these things really do go together.
Yeah. A prominent leader in our field in the area of AIDS psychiatry or HIV psychiatry is Glenn Treisman. And he really points out very nicely how important it is for us to distinguish demoralization from depression, with depression being a disease of the brain. It just happens. Neurotransmitters are not firing like normal. You don't get your yes. And that's where medical intervention helps. And then for demoralization, which is bad stuff going on in life, and that especially is true among young people. It's all of us, but especially young people. And then talking about or having someone to talk about. Did you get a sense that this was equal amounts of true depression versus demoralization? Or what was your take as you looked through the data?
So they really use screeners for depressive symptoms, and they looked over time. So I think these are really people who have mild or moderate, at least are attesting to mild or moderate depressive symptoms. I think it's interesting. There are some other studies that looked at women and looked at depression and anxiety and sort of a broader range of mental health disorders. And I think that both of them are really looking at least screeners that are pretty robust for true depression. And it is strikingly high in terms of prevalence. The good news in the studies of women is that we're doing the studies to make sure that it wasn't from dolutegravir or efavirenz, and actually didn't appear to be related to the antiretroviral therapy. It just appeared to be high prevalence across everybody, whether or not they were on antiretroviral therapy or not.
Yeah, that's great. We're almost out of time. Was there anything else that that struck you at the meeting that said, yeah, we really ought to mention this on the podcast?
So I guess for those of us who are out in the world struggling with folks with multi-drug resistant virus, for whom the long-acting dolutegravir, the long-acting cabotegravir rilpivirine regimens are not enough, there was some really encouraging data about the combination of cabotegravir, rilpivirine, and lenacapavir. And so that is not really approved as a regimen, but can be used and was used pretty effectively in a couple different studies to achieve viral suppression in people with multi-drug resistant virus. So I thought that was exciting as well.
Right, and that kind of makes sense. I mean, for folks who aren't familiar with lenacapavir, that's a drug that's a capsid sort of inhibitor, and it works in two different steps in the viral life cycle. But because it's not an integration inhibitor per se, when you put it with an integrase inhibitor like cabotegravir, or you could add it to other integrase inhibitors down the road, and then perhaps the rilpivirine as well. This really becomes a exciting approach, and both of them have long half-lives. And lenacapavir, I assume, was given sub-Q, or was it? Yeah, okay. So that means it becomes a long-acting, and so you give two long-acting drugs. And that's going to be the wave of the future, I think, almost certainly. All these medications are now pivoting to less frequent dosing and long-acting regimens. So we'll look to hear more about that next year when we repeat the podcast with you, and you can give us further insights. Barbara, it's been great having you with us today. I'm sorry the time went by so quickly, but you've covered a lot of ground, and I know folks are going to be very excited to hear this and hear more about it over time. So thanks for being with us.
Thanks so much for having me, Mike. Thanks for dedicating this to Scott. I know he was really transformational for me as a HIV care provider and a researcher, and he changed many of our lives. So.
Yeah, all of us, yes. Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.